Hi, my name is Pascal Hansen, and today I'm going to present my findings on the work that I've performed in a research project at Johns Hopkins University and the Intelligent Medical Systems Group at the German Cancer Research Center. Within that work, I focus on developing an online surgical task planner for autonomous robotic surgery. But first, why would we actually need autonomous surgery? The answer is quite simple. Due to the demographic change, already in 5 years, in 2030, there's going to be a shortage of 20,000 general surgeons in the US alone, which means that the remaining surgeons will face about 50% more workload, potentially leading to more surgical errors, and thereby raising mortality rates and reducing overall quality of patient care. Therefore, to prevent this, autonomous robotic systems could help balance out this increase in workload by performing, for example, simple routine surgeries. But how far are we actually with the research in autonomous surgery? Already before, there existed approaches to perform single surgical tasks in a controlled environment, like knot tying, needle pickup, and so on. However, these models are not able to perform long horizon tasks, as for example entire surgical procedures that could last multiple hours. And as the jump from task autonomy to procedural autonomy is quite large, in the project that I worked in, we focus on surgical phase autonomy, lasting only a couple of minutes instead of hours. Specifically, we focus on the clipping and cutting phase within the cholecystectomy, so the removal of the gallbladder. And this surgical phase can be further divided into multiple surgical tasks. And as mentioned earlier, there existed already a model, here referred to as low-level policy, that is able to perform single surgical tasks. Therefore, we reused the existing policy and guided it with the task planner, so-called high-level policy, that dictates which surgical task should be performed next, from a fixed set of task instructions defined as a classification problem. Thus, we plan to perform the entire clipping and cutting phase fully autonomously on ex vivo pig tissue. And my focus was on the high-level policy in this project. So the following slides are trying to answer how can we design a robust high-level policy for autonomous surgery. First of all, the granularity of the issued instructions is crucial. Therefore, we divided the surgical phase into 17 more fine-grained surgical tasks. However, just providing task instructions alone is not enough, as it's likely that the low-level policy will make mistakes and requires interventions to recover effectively from them. In those cases, the high-level policy will therefore issue corrective instructions from a fixed set of corrections. For example, that the clipper should be moved back to the right if it missed clipping the duct, or to open the grasper if it failed to grasp the gallbladder neck in the first attempt. After the initial manual data collection and training of the policies, we used the autonomous framework to collect more data. When then the high-level policy had made a mistake, such as a wrong task instruction or missed issuing a correction, we manually intervened or even relabeled the wrong prediction and post-processing. The collected data has then been used to further fine-tune the high-level policy to improve on situations that had failed during the previous autonomous data collection step. And this process has been repeated multiple times until the autonomous framework performed the entire surgical phase successfully. After the fine-tuning of the high-level policy, we continued with live experiments. Our core study focused on the entire surgical phase execution on 8 unseen tissues. And in all of these experiments, the designed autonomous framework was able to perform the surgical phase correctly, with just minor individual mistakes of both policies which did not affect the system-level performance. In additional ablation studies, we left out some of the main features of the high-level policy to evaluate its effectiveness on the most critical surgical tasks and recovery scenarios for 3 unseen tissues. For example, if we leave out the high-level policy completely, the success rate on tasks and recovery scenarios is only 33%. When adding the high-level policy but not applying the post-fine-tuning, the performance increases, but still it fails every 4th demonstration. When leaving out the corrections, so issuing only task instructions, the performance on the surgical task was optimal. However, the framework would still struggle when encountering recovery scenarios. Finally, when adding all features back together, the proposed autonomous framework performed successfully on all demonstrations, showing a robust performance across surgical tasks and recovery scenarios, and overall marking progress from task to phase-level autonomy, representing an important milestone toward fully autonomous surgical procedures.